lectures, we have already discussed that how the complement system work, how it can be activated, is that right? And now we will be talking about that how complement system is biologically regulated in our body, because complement products and system should not be abnormally and unduly activated in a healthy person. It should only be activated when there is need of stimulation or help of immune system, or we need augmentation to the inflammatory reaction. So first we'll repeat just few steps how complement system is activated, rather you will tell me. You have studied that in the last lecture, and then we'll talk about regulation. So you will tell me how the classical pathway is activated. If this is the bacteria, this is the antigen, right? If this is classic pathway, which antibodies should be there? What type of antibodies should be there? IgG and yes, IgG and IgM, right? General Motors, IgG, IgM, right? So once these antibodies present with the antigen, Fc portion of antibody is activated, and this start activating the complement through classic pathway. In classic pathway, yes, which complement factor is first of all activated? C1. And then activated C1 will activate which complement? Yes? C4. C4 will lose one part. What is that? C4A, and part which remains behind is C4B. Now C4B will activate the another complement, the next one, which is that one? C2. It will lose which part? C2A, and which part remains behind? C2B. You remember B for binding. So always remember B part remain bound with the main system. I told you in the last lecture, these are the apples which go away, babies remain there. Babies lose the apples. Babies mean B parts which are staying there. A mean apples are losing. So in classical pathway we discussed that antibody activates C1, C1 activates C4 and break down C4 into A and B. A is into fluid form, fluid phase lost, and B remain there, which activate C2. You should tell me, I have given the lecture, and C2B remain there, and what is lost? C2A. And both of them together are called C3. Yes, please. C3 convertase. They are called C3 convertase enzyme. Now, after that, there is a central molecule which is stimulated. What is that central molecule? Yes, C3. It fragments into two parts. Apple goes away. What goes away? C3A. What remains behind? C3B. And this complex, which include all this, it means it include C4B plus C2B plus C3B. All these three together, what are they called? C5 convertase. So they are called C5 convertase, right? C5 convertase binds with, yes, C5 convertase will activate which and product? Now C5. Again, which will be lost? Apple. C5A. What is left behind? C5B. Is that right? Then, yes, what will be activated next? C6, 7, 8 and 9. And C5 to C9 whole this complex is called membrane attack complex. That is called good. Membrane attack complex. And this will attack the membranes of the bacteria and produce perforations, and bacteria will be dead. Am I clear? This is one pathway. Of course, it's very logical that it should be only activated when there is need of it, because if it is unduly activated, such product will be produced in the body and they may damage our own tissue. Or if this is unduly activated, inappropriately activated, these products are produced which will activate the mast cells and unduly produce inflammation. Or if they are unduly activated, this will not only activate the mast cells, C5A will also attract neutrophils and undue neutrophilic activity. Is that right? So they should be only activated when there is a need. We'll talk about their regulation. This was classic pathway. Then we have discussed in the last lecture another pathway which was called alternate pathway. In alternate pathway we discussed that IgG and IgM are involved or not involved? They are not involved. That is why they are not classical pathway. They are not General Motors. They don't make classical cars, right? Now, in alternate pathway, what really happens? In alternate pathway, there are some molecules on the surface of bacteria or surface of virus or surface of fungus which can directly activate the complement system. Especially endotoxins present on the surface of gram-negative bacteria. Endotoxins which are present on the surface of gram-negative bacteria, they can activate alternate pathway. Another thing, alternate pathway can also be activated by aggregated IgA. If there are many IgA molecules which are making a clump and aggregation and deposited on some surface, they can activate alternate pathway. You may be thinking that why am I stressing this point? Let me tell you, in some diseases, IgA aggregates are formed in our body and they are not removed. So classical pathway will be unduly alternate pathway will be unduly activated and tissue will be damaged. Do you know some disease like this? No. There is a disease which is called IgA nephropathy. Have you heard the name of it? Or it is also called Berger disease, IgA nephropathy. In these patients, IgA aggregates are moving in the blood and they get stuck with the mesangium in the glomeruli. And glomerular mesangium, they get adherent to that. And when a lot of IgA aggregates bind with the mesangial deposit there, alternate pathway will be activated on the glomerular structure. And if that is activated in the glomerular structure, those inflammatory reactions will damage the glomeruli and produce proteinuria and hematuria. And we call the person is having Berger disease or IgA nephropathy. Am I clear?
Yes.
Is that right? There is another disease in which IgA aggregates are accumulated under the skin and in the GIT. And there is inappropriate activation of alternate pathway under the skin and in GIT mucosa. So there are skin lesions with GIT dysfunction. If you tell me the name of the disease, I can offer you $100 because luckily today I have. Someone paid me right now. Who likes to have $100? You likes to have, but you have to give the answer also. Okay, let's have this. If you give the right answer, I give you $100. And if you give wrong answer, you give me $100. IgA aggregates present in GIT mucosa and under the skin and inappropriately activating the complement system, alternate pathway, and producing a disease. Yes. Yes. No idea. Dermatitis herpetiformis. You never heard of it. Dermatitis, inflammation of skin. And initially it was wrongly thought that it is due to herpes. So it was given a name dermatitis herpetiformis. Right? Okay, I will give you another disease in which IgA aggregates deposit in body. I just by the way remember in this lecture. Right? That IgA aggregates move in the body and they are not cleared. And they deposit into multiple tissues in the body. Let me tell you. Some of them deposit in the GIT. And usually child develops abdominal cramps. Some of them develop into synovial membrane, polyarthritis. Some of them develop under the skin rashes. Some of those deposits develop in the glomeruli, proteinuria. Some of them those deposits develop in the lymph nodes, lymphadenopathy. You have to tell me diagnosis. Okay, I will put the classical clinical situation. 7-year-old child had 1 or 2 weeks back upper respiratory tract viral infection. After that he developed fever with abdominal pain, rashes especially on lower limbs, polyarthritis, proteinuria, generalized lymphadenopathy. Please tell me the answer. Even some pleuritic pain and to be very classical pericardial pain also sometimes. Have you heard of Hino-Shaolin purpura? Never heard of things like this. You never go beyond ischemic heart disease. Hino-Shaolin purpura. Right? In this condition, what happens? IgA, baby developed first viral infection. respiratory tract. And you know mucosal antibodies are IgA. IgA is the antiseptic paint on the mucosa. So when he developed the respiratory viral infection, he made a lot of IgA. But in this baby, IgA clearance mechanism was not good. So IgA, which was spilled into blood, made aggregate and could not be cleared. Normally it is the duty of the liver to remove It is duty of the liver to remove the IgA aggregates from the blood. So these aggregated IgA deposited in multiple areas. When they developed under the skin, complement stimulated inflammatory lesions, rashes. When these deposits develop in the GIT mucosa, abdominal cramps. When these deposits were there in producing inflammatory lesion and glomeruli, what was there? Proteinuria. Is that right? When these deposits are caught into lymph node, generalized lymphadenopathy, it's so easy to explain. Such deposits love to bind with pleural membrane and pericardial membrane, so sometimes they may develop pleuritic pain and pericardial pain. Is that right? And in few days, liver will eventually remove these IgA aggregates and baby will be okay. And after a few months, he again developed the respiratory tract infection, and again that is followed by all these things. Is that right? So Henoch-Schönlein purpura. This is another dysfunction, that IgA aggregates were not removed from the blood. Am I clear? Right? Now, let's talk about how alternate pathway was activated. We were discussing it last time, and this is suppose endotoxins or IgA aggregates. Right? Now, who will bind here directly? Yes. Do you think you need IgG, IgM? No. In this case, what will bind here? C3, B will be there, and what will be left away? C3A. Is that right? Now, C3A goes away, C3B is deposited here, and with deposited C3B, another protein comes and bind. What is that protein? Yeah, that is called, very simple name, B factor. B factor. And as soon as B factor touches, it breaks down to B A factor and B factor. So what remains there with this B factor? What is lost here? B A factor. These two together act as C3 convertase. So they activate one more molecule of C3. So what is there? Yeah, another C3B deposited. C3B deposited, and what has gone away? C3A. Is that right? Now all three together act as C5 convertase, and they activate C5, and what is lost? C5A. What is left behind? C5B, and what will bind with it? 6, 7, 8 and 9, and they will make perforations and kill the bacteria. Am I clear? So this was your classic pathway, this is your alternate path. We know the pathways. Now we have to see how they are regulated. This is the real topic which I wanted to discuss. How they are regulated. The very first factor for regulation of especially classic pathways, the presence of antibody. Presence of antibodies. If antibodies are not there, can classic be activated? No. If antibodies level is high in a particular area, complement production and activation will be more. And if antibody level in some tissue is less. So one of the very important factor for classic pathway activation is that IgG, IgM should be there, or any one of these two should be there. Secondly, not only IgG, IgM should be there, but it should be complexing with the antigen, because normally IgG, IgM is circulating in the blood without activating the complement, thank God. But as soon as, and these antibodies are like dogs, they keep on moving, but as soon as they get the bone, they start moving the tail, and tail activates the complement system. So these antibodies, IgG and IgM, are circulating in the blood, but if antibodies are not having the antigens, they are unable to activate the complement, thank God. They don't activate. But as soon as these circulating antibodies reach to a point where there are antigens, as soon as antibody, this is the antibody without antigen, this is the antibody complex with antigen. As soon as antibody complex with the antigen, IgG, IgM, this portion become active. This is the part which can activate the complement. So what does it mean? Another factor which controls the activation of classic pathway is the presence of Antigen-antibody complex, not just antibody. Is that right? These two very logical things which are required for activation of the classic pathway. Then there is a very special regulator. What is that regulator? As I told you that in classic pathway, this is the antigen, here is suppose antibody, right? And this antibody is complexing with the antigen, and I told you in the previous lecture that as soon as antibody reacts with the antigens, it exposes certain areas. These are the areas, and these areas are able to react with C1. Is that right? Let's suppose C1 bind here. What is this binding here? C1. And what is here binding? C1. Am I clear? Now, as soon as C1 start binding here, it activates is proteolytic activity. What is this? Proteolytic activity. Is that right? But there is an enzyme present in the blood, and this enzyme is called, yes, this is not happy with this activity business, this is called, yes, C1 esterase inhibitor. What is this? This black enzymes or black proteins inhibit the activity of C1. So they are positively regulating system or negatively regulating? Negative regulators. So all of us, thank God, have sufficient amount of C1 inhibitors or C1 esterase inhibitor, so that there should not be inappropriate activation of classic pathway. Is that right? To really activate the classic pathway, there should be so much C1 activated that C1 inhibitor should be overwhelmed. Let me repeat it. If really there is a lot of antigen and there is severe stimulation and the antibodies, then antibodies will produce so much C1 that they will overwhelm their or overcome their inhibitor. Only then pathway can move forward. So it means there should be lot of C1, so that first it neutralize the C1 inhibitor. Only then it can activate the pathway. So we can say that C1 esterase inhibitor is the negative regulator of C1. Now you may be thinking, why Dr. Najib is so concerned about this, that your students should know that there is an inhibitor? Because their disease is related with that. There is a disease, you will tell me the name of the disease, I tell you the condition. In that disease, there is inherited defect, genetic defect, and person does not make C1 inhibitor in sufficient amount. So person is deficient in C1 inhibitor. So such person who has deficiency of C1 inhibitor activity, classic pathway will be underactivated or overactivated? Overactivated, very natural. It's like a car without brakes. When classic pathway is overactivated, then C2A, 4A, 3A, 5A, all these are produced more or less? Yes, they produce more. And if all these products are produced more, these products can activate the mast cells. Mast cells have receptor for C3A, they have receptors for C5A. Mast cells are sensitive to even C4A, and when these things touch the mast cells start producing histamine and other products. So it means the person who has inherited deficiency of C1 esterase, he has unfortunately producing overproduction of the product of classic pathway, which may stimulate the mast cells, especially under the skin and under the mucosa. Because under the skin, mast cells are very abundantly present normally. And under the GIT mucosa and other mucosal lining, mast cells are present normally, physiologically, abundantly. So in such patient, mast cells inappropriately are stimulated under the skin and under the GIT mucosa. And what is there? They produce a lot of histamine and other product. And these product of mast cell will produce vasodilation and increase permeability. Endothelial cell shrink in microcirculation. So there will be edema. of the mucosal membranes and edematous and reddish lesion under the skin. Is that right? Especially these patients sometimes develop very severe edematous swelling of lips, nasal mucosa. Some of them develop so severe swelling of laryngeal mucosa, even they asphyxiate and die. Right? Very special thing about this is that these type of rashes don't itch. They are not itchy, they are not pruritic. Right? This is a rare condition, but very interesting that some people have inherited defect, unfortunately, of C1 inhibitors. So C1 activity in their body is inappropriately more, and under certain stresses, they inappropriately activate the products of classic pathway, and that produces severe edematous and inflammatory layer in the mucosal membrane and skin. What is the name of the condition? Yes. I think I will give only $50. Please, I think you seem to know the answer. Yes. No, $10 fine. Yes. Who will tell me the name of the condition? C1 esterase inhibitor. Very hot question in USMLE. They love to answer this thing. What is the condition? It is called, when I will tell you, you say, yes, you heard it somewhere. This condition is called, Gavin. Before you tell me something which no one knows in the world, I must answer. The condition is called angioneurotic edema. Yeah, right. Angioneurotic edema. You must be thinking why it is called neurotic. Because sometimes it is precipitated under anxiety. So people thought maybe it is due to some neurotic dysfunction. Is that right? Later on, now we know what's wrong with these people. Thank God this dysfunction is very rare. But it classically highlights how important is C1 inhibitor. So, one of the regulator for the very early step of classic pathway is C1 inhibitor. And now you know the deficiency of it. That if it is deficient, what will happen? You will develop angioneurotic edema. Am I clear? Okay, now talk about some other regulators. Let's talk about alternate pathway regulator. I will draw the alternate pathway here again. Yes, what was this? C1. This was C3b. This is C3b. And what is here? This activates which one? BB. And both of them together activate? Yes, please, hurry up. Please tell me C3b. Right. Now, these three together are called C5 convertase. For this pathway to go ahead, there should be enough C3b there. There should be enough C3b there on the membrane in active form. Is that right? If it is there in enough amount, only then this pathway will go further and work. Right? There is a regulator applied here. And a very important thing. This point is regulated positively as well as negatively. Right? Positive regulator for this is properdine. There is a protein called, protein is present in the blood. That protein is called properdine. And it loves to put them together. This protein which keeps them together so that they work well. This is a very proper protein for enhancing their activity. So we call it properdin. This properdin protein is actually stabilizer of this complex. So it means it positively regulates the activation. Am I right? Because if properdin is more there will be more activation, and if it is less there, if properdin is absent, this pathway will not work further. Is that right? This is positive regulation. But the same step has negative regulator also. The same step has negative regulator as well. Okay, I will make, this is the central, and again this is C3. Yes, please. B. BB. C3. B. C3b, C3b, and BB. Am I clear? Now, there is a negative regulator also. If there is enough properdin, this pathway will go ahead. But there is another protein. I think it should be made black because it's not good. This protein actually grabs C3 only. It holds the C3. And once it is holding the C3b, only then another protein will come here, the friend of it. The friend of this one, that will sit over here. This is the friend. Is that right? And you know what this friend will do? It has a cutter. And it will, you can say, it will so first one is holding it and second one is cutting it. And if this complex is working well, it will be constantly destroyed. Can pathway move forward? No. So it's positive regulator or negative regulator? Negative regulator. This is called, only very simple name, this is called H factor. H factor. Right? And this is called, yes, I factor. Thank God they did not put very complex name for them. I remember it in a very simple way. H factor will hold, H for H factor of course, and H for holding. H factor will hold, I will go to cut. But you have to hold it. Is that right? So simple. Now you may be thinking, why you know this? When I will teach you nephrology, there is a special type of glomerulonephritis in which there is some immune dysfunction of these proteins and person develops glomerulonephritis. Is that right? Right now you just trust me, I'm right, that for this pathway there are positive regulators and there are negative regulators. Positive regulator is propertine, negative regulator is H and I factors. Until these two are in big amount, they keep on digesting it away, holding and digesting, and alternate pathway will not be inappropriately stimulated. Is that clear? There's no problem with this? Sure? Okay, after having said all this, let's talk about one more thing. No one asked me a very important question. You should have asked one thing, that if there are so many bacteria, there are so many immune reactions which may occur in our body, so if complement system is activated, why it does not damage our normal cells? These are like time bombs. These are small bombs which are stimulated to damage the bacteria or fungi. But usually they do not damage our own tissue significantly. They don't damage our healthy tissue. They may damage the tumor cells, but they don't damage our healthy tissue. What could be the reason? I will ask a very important question in a very simple way. Let's suppose I have an inflammation in this area. Blood is coming from arterial sites, passing through capillaries and going back through venous site. If there is inflammation here, complement are activated. If complement are activated here, RBCs which are passing through this area, complement should attack them and produce hemolysis. But do you think normally hemolysis occur? No. It doesn't happen that every inflammatory area when RBCs pass by they break down. Do they break down? No. It means that our own cells like RBCs, WBCs and platelets should have some defenses against the complement product. And which complement product is most dangerous? C5b, 6, 7, 8, 9. That is membrane attack complex. This is a very dangerous product. And our cells should normally, physiologically, should have some defense against that. Do you know some defense mechanism against that? Or I should tell you? Our cells have to defend against, if you are going in the war and throwing everywhere bullet, you should have a bulletproof jacket. So RBC should have some defenses, so that it's passing through the war zones, but it should not be undergoing hemolysis. Yes. Who will tell me? Okay, I will tell you. Right, listen. I will tell you. Actually, microbes do not have certain proteins which we have. Many of our cells have special protein on their surfaces, and these proteins which are present on the cell surfaces, any activated complement factor come near, they just cut it and destroy it. Is that right? Should I tell you those products which are protecting us? Okay, do you know that RBCs, WBCs and platelets are derived from a single cell, pluripotent stem cell? There is a pluripotent stem cell in the bone marrow from where RBCs, WBCs and platelets are derived. Let's suppose this is a pluripotent stem cell. It has a nucleus. In the nucleus, there is a special there is a special gene. This gene produces the product. And this product is, this product is producing a protein, and this protein is anchored in the cell membrane. This is cell membrane. Is that right? And this protein which is anchored in the cell membrane. Is that right? Now, on this blue protein, which is providing a base, what is this thing? This is complement cutter. This is another protein which is anchored on that. And in the future, this system will be inherited by RBCs, WBCs and platelets. So all of them will have such cell membrane protein. At the top of this, there are complement inactivating proteins present. So that when RBCs are passing through some very dangerous area of inflamed area and complement are trying to attack, RBCs keep on neutralizing the complement and pass happily through them. Are you clear? One of this protein which inhibit the complement system is called decay accelerating factor. It accelerates the decay of, breakdown of C3 convertase and C5 convertase. Another name for the same thing is CD59. Similar proteins, similar functions are done by CD59. Similar functions are done by another protein, CD55. So there are many different type of proteins which are present on the cell membranes, which are acting as complement cutters, so that when complement try to destroy our own cells know how to protect them. These are the dogs to bite others. If they come to us, we shoot them. Is that clear? No problem? Now, again, why I am telling you? Because there is a very important disease in which the system is disturbed. There is no fun in learning the basic if you don't know the clinical related with that. Am I right or wrong? In the end, you are going to be doctor. So doctor should know the clinical diseases, and these days modern doctors should know the clinical diseases in relation to molecular basis. So there is a disease in which, look at it, we'll start from here. This is mutant. This gene is called PIGA gene. I will not go into detail. Phosphatidyl, inositol, glycan A protein. This gene produces a protein which produces an enzyme. That enzyme produces these anchor proteins. Is that right? Actually, if this is mutant, if this gene is mutant, can you produce these anchor proteins? And if you cannot produce the anchor proteins, can they properly anchor? No. So cells will not have enough defenses. You get me? There's a disease. This is acquired disease, that there's a mutation occurs in some pluripotent stem cells in the bone marrow, and due to that mutation, right, the proteins which provide the anchor space for the decay accelerating factor and other complement inhibiting proteins, for them this base is not there. Let me repeat, it's worth repeating. That there's a disease, of course I will ask you the name of disease, but first you listen. There's a disease in which there's acquired mutation. It is not inherited disease, it's acquired disease. So due to mutation, right, we are unable to produce those proteins which act as anchors for complement inhibiting proteins, like anchors for decay accelerating factors are not there. Anchors for CD59 and CD55 are not there. So can such RBCs, WBCs and platelets protect themselves from against the hostile complement? No. So what happens to these patients? Look, in these patients, especially at night, RBCs are unable to protect against the complement. Maybe one factor is that at night breathing is less, carbon dioxide is retained, and in acidic environment complement are more activated. Anyway, what happens that these patients have RBCs, WBCs and platelets which are more vulnerable to the attack of complement. So they tend to develop what? They tend to develop hemolysis, right? These patients develop, number one, hemolysis. RBCs breakdown inappropriate. And this hemolysis occur within the blood. RBCs breakdown within the blood. They develop intravascular hemolysis. And these patients, when in the morning urine, they find hemoglobin. You know, RBCs have hemoglobin. You must be knowing that. And then RBCs break down, hemoglobin come out. And hemoglobin molecule, the small molecule, they can leak through glomeruli and appear into urine. So, if I'm having this disease, RBCs will break down in my circulation, and from broken RBCs, what will release? Hemoglobin, and hemoglobin will go into urine, and I will have hemoglobinuria. What problem I will have? Yes, please. Hemoglobinuria, especially in the morning, right? Because urine is concentrated. Number one. Number two. With this, there may be also, that is less traumatic, there is damage to the neutrophils, so more infections. And there is inappropriate damage to the platelets, so they tend to develop venous thrombosis. Is that right? Now, they have given the name of this condition. Yes, can you tell me the name? Oh, thank God I did not offer any dollar. Thank God I did not offer any dollar. All of you know the name. That is paroxysmal nocturnal hemoglobinuria. Right? The name of condition is paroxysmal nocturnal hemoglobinuria. Now let me tell you the things. Paroxysmal is a misnomer. It should not be called paroxysmal, because usually majority of the patient have chronic hemolysis, not episodic. Is that right? Nocturnal is also misnomer, because they develop hemolysis in the daytime also, not only during the night. But usually, because in the morning urine is concentrated, so hemoglobinuria is more visible in the morning. Urine is brown, but even in the daytime urine you check, hemoglobin is there in these patients. Hemoglobinuria is also misnomer, because not only they have hemoglobinuria and hemolysis, not only they have damage of the only RBCs, they have damage in platelets and white blood cells. So, you have to remember one thing: paroxysmal nocturnal hemoglobinuria is a misnomer. Usually, condition is not paroxysmal in majority of the patient. Usually, condition is not nocturnal in most of the patient, and usually it is not limited to only hemoglobinuria, but there is damage to the neutrophils and platelets as well. Right? But anyway, when they discovered this disease initially, right, they were able to appreciate these things more than other dysfunctions, so they put the name paroxysmal nocturnal hemoglobinuria. So now you know what is the pathogenesis of paroxysmal nocturnal hemoglobinuria. You want me to repeat, or it's enough? Okay. You can rewind the video if you want to repeat. Right. So we can say decay accelerating factor was also one of the regulator of activity of complement system, because until it is there, it inhibits the complement attack on our own tissue. Is that right? Because decay accelerating factor especially keep on destabilizing C3 convertase as well as destabilizing the C5 convertase, so it does not allow the formation of enough C5b6789, that is membrane attack complex, and protect our tissue against it. Any question here? There's no question. Let's have a break. Yes. Now we will discuss few more clinical points related with the complement system. Let's talk about deficiencies of complement factors. Some people have deficiency of early complement factor, especially deficiency of C3. If you have deficiency of C3, you have a tendency to develop staphylococcal infections, right, or gram-positive bacterial infection, especially in the sinuses and respiratory tract. Usually in USMLE they put a question like this. Because it is inherited, they say there's a child who is coming again and again with unduly high frequency of sinus and respiratory tract infections, and every time infections responds very well to the antibiotics, but again infections develop. What could be the reason? Is that right? There could be many reasons. One of the reasons is that baby may have deficient levels of serum level of C3. Because when C3 is not there, then of course you cannot make C3b. And C3b is the opsonin. You know, C3b is opsonin. And if you have enough C3b, then against the bacteria, when you activate the complement, you generate enough C3b. And if bacteria are, this is a bacteria, right? If they are having a lot of C3b deposited on them, this is for C3b deposited on bacteria. You know that neutrophils and macrophage have receptor for this is the receptor protein for C3b. So C3b on one side holds the bacteria and other side it holds the neutrophil, so that neutrophil can very efficiently phagocytose and destroy the bacteria, and bacteria have no chance to escape, right? And when you have low level of C3, you have a high tendency to develop respiratory tract infections of gram-positive bacteria. Then this is about the initial factors. If you have deficiency of terminal factor means C5, 6, C5b deficiency of 6, 7, 8, 9. It means you are not able to make membrane attack complex, or any one of these is deficient, or multiple of them is deficient. Then Mr. Abdul should be knowing what type of infection occur. Neisseria gonorrhea or Neisseria meningitis. For some unknown reason, they say that these factors are really required for destruction of Neisseria gonorrhea and Neisseria gonococci and meningococci, right? Most probable reason is that those bacteria are better attacked by membrane attack complex. Is that right? Other immune wings don't handle those bacteria as well. So if you have inherited deficiency of any one of late factors, then you are unable to make enough membrane attack complex, and especially Neisseria infections become very common. From here it reminds me one more condition in which Neisseria infections are very common and related with complement system. Some people have inherited deficiency of menin binding lectins. You remember I taught you in the last lecture there is menin binding lectins present in our blood, and these substances bind with the bacterial menins, and then these substances activate C2 and 4. There's no need of IgG, IgM, and there's no need of C1, and that is called lectin pathway. She knows it so well. Is that right? So some people have deficiency of this thing and lectin pathway does not work. For some curious reasons, again, Neisseria infections are more common in them. So here are Neisseria infection, and here is also Neisseria infections. And what are the infections here? Gram-positive, especially Staphylococcal aureus infection in paranasal sinuses and upper respiratory tract when there is deficiency of C1. Am I clear? So these three deficiencies are clear. Then C1 esterase inhibitor deficiency, we have already discussed that if C1 esterase inhibitor is deficient, which disease will occur now? I will not offer any dollars. Yes? Angioneurotic edema. Thank you very much for remembering that. And then some people have deficiency of especially C2 and C4. They have inherited defect or acquired defect, chronic deficiency of these two factors. So in these patients, immune complexes cannot be eliminated. Let me tell you how immune complexes are eliminated. Because let me correlate few facts. Fact number one is that people who have C2 and C4 deficient, they have a high tendency to develop SLE. SLE is systemic lupus erythematosus. The very special point about this disease is the multiple autoreactive B cell activated which produce the autoantibodies against multiple tissue. What happens in SLE? Multiple B cell clones are reacting against your own tissues. There is polyclonal activation of autoreactive B cells. So antibodies are directed against DNA, antibodies are directed against RBCs, WBCs, platelet, skin component, and so many other things in SLE. You can, best way to remember SLE is, I'm just kidding, but it is true. You make a big bag and put a lot of autoimmune diseases into that and close the bag. The whole bag is called SLE, because in SLE, so many autoimmune reactions against so many tissues. Now, you must scratch your own head. I cannot scratch because there are less here. If you scratch your head, you should come up with the answer why deficiency of C2 and C4 should produce more chances of SLE. Yes. Should I answer? Let me tell you. Actually, in all of us, every day there are a lot of antigens coming and antibodies react with them. And antigen-antibody complexes form. These immune complexes, which are regularly formed in most of us, should be rapidly eliminated. They should not deposit here and there in the body, because if these immune complexes get deposited into multiple tissue, they will activate the complement and produce inflammatory lesions. Am I clear? That normally we are producing a lot of immune complexes. Thank God these immune complexes are very rapidly cleared. Because if they remain in our body for a long time, they deposit here and there and produce a lot of undue activation of complement system and inflammatory reactions. Am I clear? Now, first of all, we should know how immune complexes are normally cleared. Let me tell you. Let's suppose these are the antigen which is present in your body, right? And these antigens are, let's suppose, present in your blood in high amount. Antibodies will come and bind with them. Am I clear? When antigen-antibody bind, IgG or IgM, their tails will become active. And activated tails will produce what? Yes, C1, 4, 2, and C3b. Is that right? Of course, 4b, 2b, and 3b. 3b is very important. Why? Because it is opson N. Right? So C3b receptors are present on what? The C3b receptor present on phagocytic cells. Is that right? So, listen carefully, that antigen-antibody complexes may partially activate the complement up to what degree? C3b. And then C3b stick to neutrophil and macrophage. And neutrophil and macrophage rapidly eat up whole this complex. This is how normally physiologically antigen-antibody complexes are removed from your circulation. Am I clear? Really? Now, if you have chronic deficiency of C4 and C2, can you produce enough C3b and this chain can be produced? No. So can antigens be removed from your body? So antigens circulate for short time or long time? Long time. And these antigens will inappropriately stimulate the immune system and multiple autoreactions may start and SLE-like problem may start. Am I clear or just teaching myself? Really? What did I say? That what is the relationship between deficiency of C2 and C4 and SLE? We should know there is some activity of this thing which eventually, if that activity is absent, SLE will occur. First we should know what is SLE. It's an autoimmune disease in which multiple auto reactions are going on. Multiple B cells are converting into plasma cells and producing multiple autoantibodies against multiple different tissues. That is SLE, basic concept. Of course, I will teach you in detail. There will be 5 hours lecture on SLE and pathology. But here we just mentioned that it is a disease in which multiple auto reactions are occurring. Now, what is the link between two? We'll make the chain. Actually, whenever there is chronic antigenemia, risk of SLE increases. When antigens remain in your blood for a long time, we call it chronic antigenemia. Risk of autoimmune diseases increases. Whenever C2 and 4 are deficient, clearance of or immune complexes and antigens out of blood is impaired. So antigens remain in your body for longer time, inappropriate overstimulation of B cells and eventually leading to SLE-like problem. Am I clear? No problem. Then we can talk about another acquired problem related with complements. Sometimes there is hypocomplementemia but not due to inherited factors. Let me tell you. If you have some disease in which there is some disease in which lot of immune complexes are moving in your blood, there's too much high concentration of immune complexes, they will underuse the complement system or overuse? Overuse. And eventually C3 will be consumed a lot and you will develop C3 hypocomplementemia. The classical example is again SLE. There are people who have normal level of initially C2 and C4 and everything, but they develop the disease of SLE, not due to this, some other reason. If you develop any autoimmune disease in which maybe that autoimmune disease is rheumatoid arthritis, or that autoimmune disease is SLE, or that autoimmune disease is any autoimmune disease in which immune complexes are circulating in the blood for a long time, these immune complexes keep on stimulating the complement system so that immune complexes should be eliminated. But if immune complexes are too much, they overwhelm the clearance mechanism and still exist in, but they inappropriately use too high amount of complement, C3 levels will go down. This is one of the way to diagnose the immune complex systemic diseases. Right? If you in SLE, one of the part of the diagnosis is take the serum C3 level. If complement factor number 3 levels are low, you can suspect that there is some disease which is consuming the complements. In many glomerulonephritis also, complement C3 levels go down. Am I clear? Really? Okay. So this was acquired. Then another condition in which C3 levels may be low is liver diseases. C3 are produced by the liver. If there are liver destruction like alcoholic cirrhosis or chronic hepatitis B, hepatitis and cirrhosis, so naturally hepatocyte mass becomes less and liver synthetic capability becomes less. So C3 levels in the blood will be less. Right? So C3 hypocomplementemia may be due to reduced production of C3. Classical example is liver diseases. Or C3 level deficiency may be due to overutilization of C3. The classical example are immune complex diseases. Am I clear? And you know, when C3 levels are very low, you are very susceptible to gram-positive bacteria, which may produce especially infections in nasal sinuses and respiratory system. Another condition in which complements are too much used is ABO incompatibility. When mismatched blood is transfused. For example, my blood group is, I have a A positive blood. Suppose this is my circulation and my RBCs are having A antigen. My blood group is A. Right? And if I need, and of course if my blood group is A, my antibody will be anti-B. I should not have anti-A, otherwise my antibodies will destroy my own RBCs. People who have blood group A, they have anti-B. And let's suppose this is another person and he has RBCs with the B antigen, so his blood group is B. And his antibodies are his antibodies must be anti-A. These are anti-A antibodies, and of course here there are anti-B antibodies. Now if unfortunately by an accidental situation wrongly you give this blood to this person, what reaction will occur? This is the donor and that is the recipient. Listen, these anti-A antibodies from the donor, when they will enter into recipient blood, they will get extremely diluted. So they will not successfully attack the recipient RBC. So when mismatched blood transfusion occur, the donor's antibodies, when they are transfused to the recipient blood, donor's antibody gets diluted in the blood of plasma of recipient, and they don't build enough concentration to destroy the recipient RBCs. But when donors RBCs come here, can RBC dilute themselves? Can the RBCs dilute their membrane antigens? No. There are thousands of the antigens which are fixated on the RBC's membrane. So when donor's RBC enter into recipient blood, and if donor RBC is incompatible, what was the donor RBC? This was B. So these antibodies will attack. So what will happen? During mismatch ABO transfusion, these are the donor's RBCs which are destroyed by recipient antibodies within the recipient circulation. And when this RBCs break down here, when this RBC will break down, it will release hemoglobin. Right? Now, exactly what happened when this is the suppose B antigen, and here was anti-B antibody. As soon as this antibody will touch this antigen, this is IgM, it will activate the and activate, yes, C1, 4, 2, 3, 5B, 6, 7, 8, 9, drill the RBC, membrane attack complex. So what happens? Next time you imagine, if you do a mistake, ABO incompatibility, then donor's RBCs in the recipient blood is attacked by the recipient antibodies, and who will suffer? Donor will suffer or recipient will suffer? Of course, the recipient will suffer because donor is free of his RBCs. These are donor's RBCs which are blasting in recipient blood. So these are donor's RBCs having the antigens on which recipient antibodies bind, and recipient antibodies activate the recipient's complement system. A lot of complement products are produced. Membrane attack complexes are produced, which lead to hemolysis of RBCs, and of course C4A, C2A, C3A, C5A are generated. They activate all the mast cells. Mast cell produce histamine, vasodilatation. Blood pressure will fall after ABO incompatibility. Mast cell will produce histamines in the lungs, bronchoconstriction. So patient develops shock. You are understanding why? That because complements are activated, C4A, 2A, 3A, 5A, they activate the mast cell all over the body. Remember, mast cells are present in all connective tissue, but they are specially concentrated under the skin and mucosal linings. Right? Once you know that, when all over the blood complement factors are generated due to ABO incompatibility, these activate the mast cells. When mast cells around the blood vessels activate, they produce a product which dilate the blood vessel. The blood pressure falls. Is that right? Then increased permeability will occur due to histamine, so rashes. Then in the bronchial tree, these products of complement, they activate the mast cell and release histamine and bronchoconstriction. Is that right? So patient, what are the problems of the patient? As soon as mismatched blood enters, patient develop pain along the line, IV line. Of course, mast cells are being degranulated around that. With that, patient will develop shock-like condition, bronchoconstriction, abdominal cramps, and pains in the loins. Why? Why? Because RBCs are breaking and releasing hemoglobin. Hemoglobin filters through the glomerular membrane, accumulating into his kidney, proximal convoluted tubule, damaging the proximal convoluted tubule, precipitating acute tubular necrosis. Do you really want to know how exactly it occurs? Okay, let me tell you. This is your circulation, and here is your nephron, right? Normally, hemoglobin is packed within the RBC, and normally RBCs don't leak in a healthy person. So hemoglobin cannot leak. But due to ABO incompatibility, RBCs are ruptured, so hemoglobin is released. The molecular weight of hemoglobin is 64 kilodalton. Hemoglobin is tetrameric protein. You know it? Right? So as this tetrameric protein come out, it breaks down into dimers. Dimers are so small they can filter down. Patient will develop hemoglobin urea. Plus, when lot of hemoglobin is going down here, it will clog the proximal convoluted tubule. And these very stupid proximal convoluted tubule, they think why this is blocked. They think this is some delicious dish of hemoglobin coming. They start pinocytosis and start eating up the hemoglobin, and hemoglobin enter into these cells, it releases the iron. Iron is highly reactive and damages these cells. So if patient does not die due to shock, he will have acute tubular necrosis, and you will see first urine will be coming with lot of hemoglobin, and then urine output drops dangerously, and he will be in renal failure. Yeah. Am I clear to you people? So this was one more example in which inappropriate complement activation due to ABO incompatibility leads to shock-like condition, and if patient survive, there may be renal failure, acute renal failure, of course. That's all about complements.